Good. So we're going to get started today with virtual education session, managing your healthcare, communication between the primary care doctor and the neurologist. Thank you for joining us today. This is Bill Pat-Jane, Executive Director for the American Parkinson's Disease Association, Massachusetts chapter. Thank you. Next slide, please. So just a few things before we get started. The APDA has been in operation for decades and offers programs and services to the PD community in Massachusetts and across the entire country. We've received a large response for today's presentation. There has been a tremendous amount of progress in understanding and treating Parkinson's disease. PD is highly individualized from person to person. Not all that is discussed today is relevant to everyone. The healthcare team must be familiar with signs and symptoms, treatment strategies, and how Parkinson's disease impacts the individual patient. Treating PD requires a team approach. And today we are providing information and is not intended as medical advice. And so before we get started, I'd like to introduce our two incredible speakers. We've been fortunate here in Massachusetts to have two incredible doctors join our board, and they'll be actually working through today's presentation. The first of which is Dr. Stephanie Bissonnette. And Dr. Bissonnette is a board certified and fellowship trained movement disorder specialist at Boston Medical Center. She completed her residency at Ohio State University Wexner Medical Center and then completed a movement disorder fellowship at Boston University and is currently an assistant professor of neurology at Boston University School of Medicine and an associate program director for the neurology residency program. She is also the director of Neurology Global Health, where she leads the Boston University Haiti Initiative. She is also a credentialed investigator for both the Parkinson's Study Group and the Huntington's Study Group, and a board member at large for the APDA Mass chapter. Her research interests include CSF biomarkers for neurodegenerative diseases, disparities in care in the treatment of PD patients, and Huntington's disease treatment and natural history. The second presenter that we have to complement Dr. Bissonnette is Dr. Terrell Johnson. Dr. Terrell Johnson is a board certified physician of internal medicine with a practice at Boston Medical Center. With a practice focused on preventative medicine, his professional goals include a focus on patient education and screening for several common conditions. He is also an assistant professor of medicine at BU School of Medicine. Dr. Johnson's areas of interest also include health disparities and increasing access of care for underrepresented groups in medicine. Dr. Johnson is a board member at large for the APDA Mass chapter. His outside interests also include community service with a specific focus helping to promote academic advancement in men of color in the greater Boston neighborhoods. We're very excited about today's two presenters and the subject matter. And so without further ado, I'd like to introduce Dr. Stephanie Bissonnette.
Thank you so much, Bill. Dr. Johnson and I are so excited to be here today to talk with you about what we think is a really important topic, how a neurologist and a primary care doctor communicate with each other to help patients with Parkinson's disease manage their Parkinson's. This is just to give you a guide of what we're going to talk about today. So we're going to start by describing the role of both a primary care physician and a neurologist in managing Parkinson's disease. And then we're going to use a case-based approach to identify some common examples of when collaboration is most important. And we're finally going to end with discussing some strategies for how people with Parkinson's and their care partners can best manage their primary care and movement disorder or neurology teams. So to start with, we just want to highlight the fact that managing your Parkinson's disease takes a village. It takes a lot of people to make sure that you are living your best life, that your symptoms are being well managed, and that your quality of life is wonderful. our goal is always to make sure that you're living the best that you can. And in order to do that, we usually employ the help of many people. So while today we're going to really highlight the roles of the primary care physician and the movement disorder specialist, we want you to know that we are well aware that not only is your family and your care partner a huge part of this team, but also people that we think of maybe as little parts of your team, but are actually really, really important, like your physical therapist, your occupational therapist, your wellness and exercise coaches, and your psychosocial support. So this is just a small portion of the people who are actually involved in making sure that managing your Parkinson's disease is easy. I'm going to turn it over to Dr. Johnson to talk a little bit about what the role of a primary care physician is.
Hello, everyone, and thank you for having me. As Dr. Bissonnette said, what we really want to do is talk about the role of a primary care physician in Parkinson's disease, just like in many diseases. Our number one goal is always primary care, preventative care. The role of a primary care physician is to help identify possible diseases, either before they happen or at an early stage so that they can be managed most appropriately. In addition to that, our goals are to screen for common diseases, especially as individuals get older, things like various cancer screenings, and to know what people are age appropriate for, either based just on their age or on their family history as well too. In addition to that, we can help them manage chronic or otherwise known as long-lasting conditions, things like diabetes, hypertension, asthma, emphysema, anything like that. And lastly, if we're unable to help someone with something, we are usually very good about knowing where to send someone. And what I mean by that, for example, is that all things that are chest pain are not related to your heart. Maybe it's related to your lungs. Maybe it's related to your stomach. And having a conversation with your primary care physician, we can help to determine where is the appropriate place for you to go. Next slide, please.
In contrast to what a primary care doctor does, a neurologist is really solely concerned with the treatment of the brain and nervous system. So that includes your brain, your spine, all of the peripheral nerves, and the communication between the nerves and the muscles. They treat conditions such as strokes, headaches, seizures, pain, memory disorders, and then there is a subset of specialists who actually treat things such as Parkinson's disease, or what we call movement disorders. These providers are called movement disorder specialists, and what they do is they do an extra 1 to 2 years of training related in things such as Parkinson's disease, known as a movement disorder fellowship. They then focus their practice after they graduate on Parkinson's disease and related disorders, and they can be especially important for helping to manage the complex Parkinson's disease medications and side effects, as well as treat other symptoms that are associated with Parkinson's disease, things that are not often thought of. So what we call the non-motor symptoms, and these include things such as constipation, urinary frequency, sleep problems. We can also do advanced treatments such as botulinum toxin injections for abnormal muscle contractions and spasms, or tremor, and we can also program deep brain stimulators. It's common that many patients with Parkinson's disease actually are treated either by a primary care doctor or a neurologist, but we would argue that it's important to have a movement disorder specialist at least involved at some point in your care. And the reason is that we actually are trained and involved in all of the new developments in the field. So when new medications come out, what research is being done in the field, we know specifically, especially in your local area, who is the most familiar with Parkinson's disease. For example, physical therapists who not just treat orthopedic problems such as knees and backs, but also treat gait abnormalities, which is walking and balance, and things that Parkinson's patients specifically have problems with. We also can actually access clinical trials, and we know where clinical trials are being done, and we're much more familiar with the community support system. So where can you find in-home care? Where can you find support groups and exercise classes? Those are things that movement disorder specialists are really adept at knowing for their patients. I'm going to pass it over to Dr. Johnson to talk a little bit about the times in which, especially for someone with Parkinson's disease, you may need input from both a neurologist and a primary care doctor.
Thank you, Dr. Bissonnette. As she discussed, there's an important role of communication between all providers on the patient's care team. We all work together to optimize your care and optimize how well you can function in your life on a daily basis. There are some conditions that are so common, not only in Parkinson's disease, but also in regular medicine, that primary care physicians are also helpful about managing these things. And sometimes these problems that we're referring to are not necessarily even related to your Parkinson's disease. Things on this list that you can see are things like bladder dysfunction, constipation, depression, orthostatic hypotension, which means that you feel dizzy when you get up from a seated position or get up out of bed in the morning, or even things like hospitalization. And the communication is key, not only with regards to medication changes, but how a patient's condition has changed over time. Traditionally, the primary care physician is the one who refers the patient to the movement disorder specialist or to the neurologist if need be. And so we often have a much better concept of where this patient has been in the last 5, 10, or even 15 years, and about how their symptoms are changing with time. And these are some of the things that we discuss and enjoy discussing with your specialists and subspecialists to help optimize your care. Next slide.
Let's start with a case to give you an example of this. So Sam is a 63-year-old male carrier who noticed a tremor in his left hand that comes and goes and seems to be worse at the end of his route. He decides to make an appointment with his primary care physician, who he last saw a year and a half ago. He's not sure if it's even worth mentioning, but since he's overdue for a visit, he will discuss it with his primary care doctor. Now, I'm sure many of you have had an experience similar to this, and Dr. Johnson, I know you and I have both seen these patients quite often. How do you approach this patient?
Well, the first thing that we're happy for is that the patient even comes in and begins to tell us what his issues are. Oftentimes, if patients don't mention it, these things can be hard to pick up, and there's a list of other things that may be going on. This patient may also have an issue with his blood pressure, may have a family issue, and things like that. So the most important thing is to bring the issue to your primary care provider. When we see a patient who has an issue with tremor or with their hand shaking, as in this case, we really begin to go through what in medicine is called a differential diagnosis, or other diseases that can be causing this, right? Not all tremor is caused by Parkinson's disease. We think about things like blood sugar may be low or high, thyroid disease. We think about medications that are on the patient's list. We think about any other possibility that may be causing this because we don't want to miss anything. You know, one of the first roles of a primary care provider is to make sure that nothing here is dangerous and is going to injure you or harm you irreparably over the next few days or even weeks. And once we kind of go through our list or our differential diagnosis about things that may be going on, we begin to think, do we need additional testing? Things like MRIs, things like blood work, things like CT scans, or maybe we need to adjust the patient's medications. And after all of that, in a case like this, if we find that all of those things are benign or kind of within normal limits, we might suggest a referral to neurology or even a movement disorder specialist. Case 2. So again, we just want to give you some different examples of ways that we communicate. Pam is a 56-year-old, has been living with the diagnosis of Parkinson's for 11 years. She saw her neurologist, who noticed she has lost about 13 pounds since her last visit. She reports she's not trying to lose weight. Describe the role of a primary care physician and movement disorders neurologist. Dr. Bissonnette, I'll leave this to you.
So one of the things that is really interesting in this case is that weight loss actually can be seen in Parkinson's disease, partially because, as many of you know, when you are diagnosed with Parkinson's, the first thing that we tell you is to start exercising. So people begin to change the routine pretty quickly after their diagnosis. They will often start exercising more. They will start watching what they eat. Not because with the goal of losing weight, but because their appetite has changed, or because they have to be more careful around their medication and what they're eating when in relation to the timing of their medication. There is also probably just a high metabolic demand on Parkinson's disease that we don't fully understand, but it is pretty common to lose some weight with Parkinson's. Now, in a patient like this who's had Parkinson's for 11 years and has lost more than 10 pounds, I start to worry that there's something outside of Parkinson's disease. And this is where I really do rely on a primary care doctor to make sure that I'm not missing something. So this is where I start to reach out to a primary care doctor, or ask the patient to reach out to their primary care doctor to make sure that there's not something else going on. Now, Dr. Johnson, what kinds of things do you usually check for when someone comes in with an unexplained weight loss?
Excellent. Well, the first role, like Dr. Bissonnette said, is communication. We as internists or primary care physicians also know that Parkinson's can lead to a loss of weight. And so the communication with your specialist to say, I don't think this is related to this, what else could be possibly going on, is the first step in the conversation. Once they've made it clear that they are not concerned that this is the issue, then I begin to think of other things. So particularly in elderly individuals who are more likely to have Parkinson's disease, and what we call the unexplained weight loss, or weight that they are not trying to lose, one of the first things that comes to our mind are cancer screenings. Could they potentially have some type of malignancy? Cancer screenings are something that definitely fall into the role of a primary care physician. And one of the things that can possibly happen at times is that these patients, or any patient who has a chronic disease, may end up seeing their specialist a lot more than they see their primary care physician, and can miss some of these important cancer screenings that can help us possibly come to a reason for why they're losing weight. In this case, we're thinking about things like colorectal cancer, colonoscopies, breast cancers, things like mammograms, lung cancer screenings, which are now CT screenings, cervical cancer screenings, also thought of as pap smears, or prostate cancer screenings. All of these things begin to go through our mind, and we begin to go through this list to determine if we are up to date on all of these various things that we have. Next slide, please.
And one of the things that I just want to interject here is that there is a slight chance of a higher risk of having melanoma if you have Parkinson's disease that has been shown in the literature. So we don't often think about getting a good skin exam, but it's something where primary care doctors actually are a little bit more attuned to when they do see patients.
You know, what we wanted to review here were just some of the common cancer screenings that we do in primary care medicine that oftentimes the neurologists may not be thinking about as much, as they are definitely focused on the most up-to-date treatments for your Parkinson's disease and research studies, and cancer screenings fall into the range of primary care physicians. One of the most important ones is that just recently in May of last year, the guidelines have changed on colorectal cancer screening. It used to be beginning at the age of 50 years old and a person at average risk, who means that a person who has no family history of colorectal cancer. But this has just recently changed because the incidence of this has increased so much. We now begin at the age of 45. And you can have a conversation with your primary care physician about the different kinds of ways to do this. Most commonly, people think of colonoscopies. There's also sigmoidoscopies or stool tests. And a conversation with your primary care provider about what is the best or most appropriate option for you is an important thing to do in a case like this. Next slide. We talk about in women breast cancer screening. Traditionally, women know that they should have a mammogram, or at least it comes into their mind beginning at the age of 50. And some recommendations even say at the age of 40. Having a conversation with your primary care physician is important to know, as some people really can wait until 50. Others may need to start at 40 or even before that. But again, if you've not had these routine screenings, and a breast cancer screening is either every year or every 2 years, there's an important way for, as we think about this case, why this patient may be losing weight. Prostate cancer screening is something that is definitely in the realm of primary care, and this continues to evolve. Traditionally, men thought of having a biopsy or a manual digital rectal exam, which we no longer do. And now the recommendations are not as clear, and that is why it's important to speak with your primary care physician. You know, it is a grade C recommendation, which means not that strong, but still a recommendation nonetheless to begin prostate cancer screening at the age of 55. But men and underrepresented minorities, for example, Black men or men of African descent, are thought to have a higher risk for prostate cancer. We'll begin screening in them at an earlier age. Prostate cancer is one of these things that people often don't recognize the symptoms, or these symptoms can be so mild at times that they often don't recognize what is happening. Men can say, you know what, doctor, I've been using the bathroom more. It feels like I have to strain a little bit when I go to use the bathroom, or that it feels like everything doesn't get out actually when I urinate, doctor. And sometimes they just chalk it up to age and don't think much of it, but it's an important conversation to have with your providers.
It's also really important to remember, it's also really important to remember that, as you can see from the signs and symptoms listed here, a lot of the symptoms of prostate cancer are also the symptoms of Parkinson's disease and the urinary dysfunction that comes along with it. So going to the bathroom more overnight or more frequently during the day, having hesitancy when you have to go to the bathroom, or dribbling urine, retaining some urine, or just having a weak stream, all can be associated with Parkinson's disease as well, which is why it is so important that you get screened with a prostate-specific antigen test, because we may never pick it up if we're only relying on those signs and symptoms, as Dr. Johnson mentioned. Moving
Scenario
on to
three.
Sorry, I was going to say the same thing. Go ahead.
Not a problem. So scenario 3, Peter is a 74-year-old and feels dizzy all of the time. At his neurology appointment, the nurse took his blood pressure, and it was 101/62 when he was sitting. And when standing, his blood pressure dropped to 80/48. His neurologist noticed he is on 2 blood pressure medications. He recently changed his diabetes medication and shared that things could be better in that department. He does not drink fluids, even though his wife reminds him all day long, because he does not want to have frequent trips to the bathroom. Describe the role of the PCP and a neurologist in this situation, Dr. Bissonnette.
So I think this is one of the most common things that I see in my clinic. So as you notice in this case, we actually check the blood pressure sitting and standing routinely when I see patients with Parkinson's disease. And that's because it is pretty common for the blood pressure to drop some, just due to Parkinson in itself, especially over time. People who've had Parkinson's going on 5-6 years, we start to worry about this. But in addition, as we're increasing medication, sometimes we can worsen what we call orthostatic hypotension by adding more of the levodopa, which can also drop the blood pressure. One of the things that becomes really, as Dr. Johnson and I were just discussing, a conversation between the primary care doctor and the neurologist is, how do you balance the blood pressure in terms of cardiovascular health and what we want for long-term preventative medication and blood pressure goals with the drops in blood pressure. So I often tell patients that we've been telling them for years and years and years that we want your blood pressure at 120 as that top number all the time. And now I'm telling you that it's okay to be 140, because when you stand, it drops below 100. And that's when you're at risk for falling and passing out and hurting yourself, breaking a hip, things like that. All of the complications that we don't want to see. So in this situation, I often will think about adjusting medications that you may have been on for a very, very long time. So blood pressure medications where, say, you're on 2-3 medications or you're at high doses of them, I will often decide to start by trying to decrease that. But again, these are not medications that I'm usually prescribing for my patients. So this is where communicating with a primary care doctor is so important, making sure that they are aware of which medications I'm thinking about dropping or changing, asking them if they're willing to or they agree with that medication, because they're, as in this case, patients have other disorders such as diabetes. And so changing something such as an ACE inhibitor, which is your lisinopril, might not be the best option for a patient who also needs that for protection of their kidneys with their diabetes. So those may be things I'm unaware of, and I need a primary care doctor who, as Dr. Johnson mentioned at the beginning, has known my patient for much, much longer and knows their whole body system to help guide me in terms of how to make sure that the medications are helping the patient and not harming them. It's also very common that treatment of the non-motor symptoms, not just blood pressure, are treated with medications that are often used in primary care. So for example, insomnia being treated with a sleeping aid, or depression being treated with an antidepressant, or anxiety being treated with an antidepressant. Again, these are things that primary care doctors are often much more equipped to prescribe because they do it more often than I may. And so this is where conversations about how to best make sure that the medications are balanced and are doing the things and treating all of the symptoms of Parkinson's disease, this is where it's extraordinarily important to collaborate with a primary care doctor. Dr. Johnson, anything you want to mention there?
In addition to what you said, Dr. Bissonnette, there's also that many times the primary care physician like myself is considered the center point of a patient's medical team. And so what we mean by that is that maybe this patient also has a cardiologist, maybe this patient also has an endocrinologist. And we're in collaboration with those providers as well too, to talk about what medications that a patient may need. Possibly a patient has some kind of coronary artery disease or heart disease. Possibly they have diabetes. Possibly they have some type of pulmonary or lung condition. And how all of these medications work together. These medications do not work solely just for your PD or Parkinson's disease, but they can often have effects in other parts of your body as well too, which we need to think about and manage as well. We may also be more inclined to know about your family history, even ask about your family history. Knowing that other members of your family have certain diseases that we are mindful of and are adjusting your medications appropriately for that is something that we think about as well too, in addition to collaborating with these other providers, really to try to optimize your care as best that we can.
One of the things that becomes very important as well is how to best guide you in terms of what to monitor at home. So when it comes to patients whose blood pressure seems to be changing with sitting or standing, or people who get dizzy when they stand up, I often do want my patients to be taking their blood pressures at home, but we've both had the experience where patients will actually worry so much about their blood pressure that they will take it multiple times throughout the day. So we really do have to work to not only give you good, clear guidelines, such as I tell my patients, I want you to take your blood pressure first thing in the morning, sitting and standing one time for 1 week, and then send me those numbers. But we can also help by sending out home care nurses to potentially help you or take the blood pressure for you if you don't feel comfortable, or if it's hard to communicate those numbers directly to us. And that's often where I rely on a primary care doctor to help me know what services are available in the area. So scenario 4 is Dan, who is a 72-year-old and has had Parkinson's for 6 years. His wife sent a message to share that he's had some episodes of confusion during the past week. This has never happened before. He also reports increased urinary frequency at night. And Dr. Johnson, can you describe the approach of care for a patient such as Dan?
One of the conversations that I have with many of the specialists, including Dr. Bissonnette, is often that specialist schedules are not built to have what we consider an urgent care appointment. And so what that means is if you wake up one morning and have an issue, we in primary care are built or have spots in our schedule for individuals like yourself who may have something that has changed, or something that makes you feel uncomfortable, or something that makes you feel nervous. And this patient in particular, who now has confusion or what we consider in medicine delirium, we have thoughts about a lot of things based on someone's age that could be causing this. Most commonly we think about things as far as infection go, a urinary tract infection, which is similar to some of those symptoms that we showed on the previous slide about prostate cancer. We think about things like COVID-19. Infection with that also has been known to cause mental status changes, or people just being funny or not at what we consider their baseline. Another lung infection is pneumonia. Oftentimes people have pneumonia, particularly in this population of Parkinson's disease, where you can have problems with speech and have problems with swallowing. And this infection can also lead to changes in mental status. And one of the biggest things in medicine, we need to come up with an idea of if someone possibly had a head injury, either recently or some time ago, that could possibly have bleeding in the brain or some other kind of effect that could be causing these changes. In addition to that, for example, as we've discussed many times throughout this speech today, individuals have other medical conditions, things like diabetes. Let's say maybe your blood sugar is too low because you've changed the way that you've been eating, or maybe it's hard for you to eat. A low blood sugar can cause you to have confusion. The same with things like constipation. The same with things like mixing up your medications. Maybe you're not able to grab the medications out of your pill box that you once did. Maybe you have different family members coming to help you. And it's our role to try to help figure out what could possibly be causing confusion in the patient. Dr. Bissonnette?
I often think that once we've ruled out all of what we consider the acute things, so the infections, the have you fallen and hit your head, do you have a concussion, those types of things, I then wonder, are you just being more confused because we're not dosing your Parkinson's medications appropriately? Many of you have probably experienced the slowness of thinking or the fogginess that can come when your medications are not working as well, or as they're wearing off between doses. And so I often rely on having a primary care doctor check for the things that are correctable and fixable. For example, a urinary tract infection can be treated with antibiotics, and that can clear things up and we don't have to adjust any other medications. But once all of that has been evaluated and treated, I then think about, am I just not treating the patient's Parkinson's properly? And that's when I will then try to get the patient in for a visit. But as Dr. Johnson mentioned, he really has the space for acute visits, whereas I often am booked for quite a while. And so it's a lot harder for me to see someone that day, that week. We're going to talk now about how to coordinate the care between a primary care doctor and a neurologist. As many of you have known, trying to navigate the healthcare system, it is an imperfect system, and communication, whether it's within a healthcare system, such as, for example, we're both at Boston Medical Center, it is a little bit easier to communicate because we do have ways to internally message each other. But even out, we have many patients who are seen by whether it's specialists or primary care providers outside of our system. So what are some of the ways in which we can help facilitate easier communication? So one thing is just making sure that your providers know who each other are. So making sure that your provider is given both to your neurologist, your primary care provider is given to your neurologist, so they know the name and phone number or the practice that that person is at, and vice versa, that your primary care doctor knows who your neurologist is, who is treating your Parkinson's disease. You want to make sure that they have contact information for other team members that might be involved as well. I often ask the patient to ask their doctor, what is the best way for me to communicate with them? So does your provider want me to call them? If I call the office, I get through the same line that you often get through, and that doesn't always get directly to the doctor. It can go through multiple channels before we actually have a face-to-face conversation. So if the doctor is more likely to want to be emailed or to have a direct phone line, those are things that I would need to know about. And I do often provide my direct line to patients to give to their provider as well. I think that one of the greatest things about our new electronic medical records is that there's multiple ways to communicate. So things such as your patient portal or your MyChart, where you can email a provider, that can actually help, and that helps us internally to communicate as well. We're fortunate here at Boston Medical Center that we also have a large community health center network, and they are all on the same network. So I can actually send emails to our community health centers, and that helps me communicate with primary care providers a lot. But again, the telephone works just as well for those people who are not as technologically advanced. So don't feel like you have to necessarily use those ways to communicate, but making sure that you are telling the doctors who each other are and what the best way to communicate helps a lot. And then the next thing to do is just make sure you come prepared to each visit, and we're going to talk about what that means.
And just to add to that, in addition to what Dr. Bissonnette said, one of the beautiful things about having a movement disorder specialist, or having really any kind of specialist, is that they often know some of the most up-to-date therapies in the field. They are in tune with what research may be going on, and you may be lucky enough to get involved in these things. Well, often a primary care physician is not aware of these newest therapies that are out. And so we are not aware of the side effects that can be related to this, or kind of medication and medication contraindications, or medication problems that this can create down the line. And so being able to speak to the physician and have that communication, knowing their telephone number, knowing their name, is extremely valuable for us. So again, so we can give you the best care that is possible. You know, when we talk about coming to see not only your primary care physician, but even your neurologist, your movement disorder specialist, we want you to be prepared so that you can have the most efficient visit that is possible. You know, to the best of your ability, please aim to arrive early. Anticipate delays and get into the office, whether it is parking, whether it is weather, whether it's traffic. Any of these things can be a problem. And we do want to see as many patients as possible to give them all the care that they deserve. Please bring a list of all of your medications, including the name, dosage, and when you started or stopped the medications. As Dr. Bissonnette said, oftentimes the specialists you see may not be in the same hospital system, and we may not know this information. And so if we can have the names and the dosages of when you started taking these medications, how often you take these medications, it can help us to update your medical record. And again, give you the best care that's possible. That's really our goal here. You know, please keep as many of your appointments as possible. We understand that people need to change and schedules change, but please try not to go too long in between visits. In general, we tell people at the bare minimum, you should see your primary care physician at least once a year. And depending on any kind of other medical comorbidities, meaning other medication problems or other medical problems that you have, maybe more than that. Some people may need to come twice a year, some people 3 times a year. Each individual is different, and please discuss this with your doctor. One thing that we really like to see patients do is bring a list, you know, in between your visits, which can be in between 3 months' time or 4 months' time. Write down your questions. You know, it can be hard to remember these things. Put them on a sheet of paper, put them in your phone, have someone else write them down to you and bring them to your physician. Hand this list to your physician and say, here are all the questions that I have. Now let's talk about these things. Because oftentimes we forget when we get into the room, we get very excited to speak to our provider. And lastly, if you use any kind of medical devices, whether it is a glucometer, a machine to check your blood sugar, or a blood pressure machine, please bring those into the office. Those are valuable pieces of information for us to give us some clue about how your blood sugars may have evolved over time, how your blood pressure may have evolved over time. When we see you in the office on that one individual day, on that one Wednesday the 19th, we can only have that value from that point in time. But you are yourself every single day, and we want to know that information. Dr. Bissonnette?
I was also just going to mention that it may be difficult as you're preparing your list of things that have been going on between visits to determine what is more important to you. So I always try to guide my patients by saying, what are the things that not only are happening frequently, but that are affecting your quality of life? They're limiting your function. They're limiting your ability to do things. That may be that it runs the gamut. So it may be things like urinating frequently, or it might be lack of sleep, or it might be your tremor. So knowing which things are the things that are really bothersome to you is really important for us to guide the visit. As many of you may have noticed, in the past couple of years, medicine has become increasingly busy, and the time in which physicians have to spend with you is getting shorter and shorter. And so knowing that you have prioritized your concerns so that we can talk about the most important things at that visit, but also asking to be seen more frequently if you need to. I will often say, if someone comes in with a list that we can't get through, I will see you in 2 months as opposed to 3 or 4 months. And that's so that we can make sure not a lot of time has lapsed between visits, so that we're progressively addressing the things that are causing your problems. So I'm going to actually turn this over to Dr. Johnson, because I'm not sure I know the answer to this, but what do you do when you don't have a primary care doctor? For example, you've moved to a new area, or you just haven't seen one in years, or your primary care doctor retired.
Yep. I actually had that experience recently. My primary care physician retired, and I myself had a hard time trying to find a provider, another primary care physician. So I wanted to give some insight to those on this Zoom call today about how to do that. Usually one of the first things that we would suggest to people is call your insurance company. Usually your insurance company contracts with different providers in the area, or possibly different healthcare systems. Know who is in your network and who you can see. They often have the most updated list of who is still accepting new patients and who is not accepting new patients. If not, try your local hospital. Call your local hospital. Call the internal medicine department. Call the primary care department and ask them, do you have a list of physicians who are taking new patients? And it's okay to ask questions. You know, it's okay to say, I want the male physician. I want the female physician. I want someone younger. I want someone older. It is okay to have a belief in who you want to take care of you, because we want you to feel comfortable so that you can tell any kind of problems that you may be having. Ask those around you who they recommend. Maybe you have a good friend or a family member who is a primary care physician who really enjoys that physician and thinks that physician does a great job. Ask them. They may be able to give you some insight as well too. Even your neurologist may have a recommendation. They may say that I have 20 patients who have Dr. Jones, or I have 15 patients that have Dr. Brown. Whatever that may be, ask them for a recommendation, as they may have some good information. And lastly, particularly now during this pandemic, there's been a proliferation of online places to find a doctor. We think here at Boston Medical Center that one that is used is something called ZocDoc, but you can always go online and look for, primary care providers in my area, or those who are accepting new patients, and see what is available to you. That is one of the best resources that you can use.
So hopefully we have given you some practical tips for how to help facilitate communication between your neurologist and your primary care doctor, and have highlighted why we think it is extremely important to have both involved in your care, so that you are being treated the best and that your quality of life is being addressed at all aspects of your life. With that, we're going to open it up to question and answer and pass it back to Bill.
Yes, thank you, Dr. Johnson and Dr. Bissonnette. Incredible information. This is obviously a very important topic. We've gotten a lot of feedback related to making sure that we're able to present information on the integration between primary care physician and a specialist. And so thank you so much for doing a great job with the content and today's presentation. I especially like the recommendation and suggestion to bring the blood pressure medication to your appointment to make sure that it's working correctly. Thank you very much for that recommendation. I'll make sure that I note that down next time I see my PCP. So one question that I have, and that we've gotten quite a few responses to today, is, as a physician, can you emphasize 1 or 2 tips that improve communication at the visit?
Can you clarify, do you mean communication between the patient and provider, or between 2 various providers?
Yeah, between 2 various providers. One of the specific questions that we have is that we've got a specialist, a movement disorder specialist, that is quite a far distance from their PCP. So this individual lives in Western Massachusetts, and their movement disorder specialist is in Boston. And so is there 1 or 2 tips that you might have that would improve the communication beyond, the information that's been presented?
So one thing that I think can be really frustrating is, even when we say we're going to send a note, a lot of times we'll print out our note, we'll fax it over, it'll get lost in the faxing system, it will get lost in the mail, the primary care doctor will get it with a bunch of other ones and miss it, and vice versa. When I ask for records from the primary care doctor, they don't always get to my desk. They sometimes end up in central records, they sometimes end up with our administrators. And so one thing that I always like to do, and I think you can probably request this from your neurologist, is that at the end of every visit, I provide a summary to the patient, and I will print more than one of those so that you can either bring it with you to your primary care doctor's visit, or you can mail it to them yourself or drop it off. I think that it is difficult to be the go-between between the two providing offices, and I would love it if there was a system that was a little bit smoother in terms of letting us communicate more effectively and efficiently with each other. But sometimes having you just request an extra copy of your discharge stuff, of your medication list, making sure that your medication list looks the same as what the doctor has printed is really important as well. We may write in our note what you're taking, but then not update the actual medical chart. And then when it prints your list, the list looks different. That actually happens quite often. And so making sure that you're double checking us, but also that you have extra copies of all the things that you're given from your doctor can actually really help facilitate communication.
And just to add on to say more of the same thing, whenever you go to another provider, whether it's a specialist, whether it's the emergency room, we almost always give you some kind of paperwork at the completion of the visit. Just bring that with you. Even if it just shows us that a medication change was made, we'll at least get our ball to thinking as to why or what happened. And it will give us the name and the telephone number for that provider so we can reach out to them, if nothing else, to find out exactly what is going on and to get more updated information.
Thank you, Dr. Johnson and Dr. Bissonnette. Another question that I have is, sometimes I feel that it is a full-time job managing my healthcare issues. Medication, insurance, therapies, etc. Would it be helpful to get a family member involved in the situation?
I think absolutely. And I think Dr. Johnson will probably agree, partially because it's always nice to have two sets of eyes on things. And sometimes having different schedules in terms of, I can call in the afternoon, you can call in the morning or something like that. And we've probably all had the experience of sitting on the phone for 45 minutes to an hour, just trying to get through either to your doctor's office or your insurance company can be extremely frustrating. And so having multiple people to help try and move things along can be helpful, but I agree, it sometimes can feel like a full-time job and can be extremely difficult to maneuver. There are sometimes, I know in this area, there are private case managers, and their whole job is actually to help you navigate the healthcare system. Some of them are pay out of pocket, but sometimes depending on where your healthcare home is, whether you're at a community health center or sometimes primary care offices will have social workers or case managers who can sometimes also help you to navigate some of that, help it check your insurance and do things like that. So making sure you're asking what resources are available, or at least letting your providers know what you're having trouble with. I'm having trouble getting my medication. I'm having trouble getting a prior authorization for my medications. Those are often things that our offices can help with. I had another thought, but it's gone. Dr. Johnson, did you have anything to add there?
I just want to add even a little more practical to that. Oftentimes when you go to these appointments with your doctor, we give a lot of information, and it can be tough to take all this information in and to remember all of this information. And having two people or two sets of ears is extremely valuable. And not only that, like when you leave the appointment, what did they say, or what did you hear, and what did I hear? And that conversation for two different people and what they hear is extremely valuable for you. So yes, we think it's important, and we want your family to be involved in your care. If they're not aware of your care, I can name you multiple patients I have who don't tell their significant others they have diabetes, or don't help to control their diet, and that can be an issue for your overall care. So yes, please bring somebody to the visit with you. It can only help.
And I thought I had my thought come back. I was going to say that having someone else who maybe is more adept at sending emails, if your adult children are online all the time for their job, giving them your password for your portal, giving them permission to talk to your doctor can be really helpful, especially because it's a handwritten record. So a lot of times if I'm changing medications and it's complicated, having it in an email that you can then print and put on your fridge or look at on your phone or your tablet when you have questions or concerns, or again, you don't remember what was said, that can be so helpful just to make sure that things are being done properly.
Yeah, and I know that one of the things that was in today's presentation is finding out exactly the best way to communicate with your doctor. And it may be email, it may be phone, it may be the old-fashioned way via, the mail. I have another question specifically for you, Dr. Bissonnette. One is involving neurologist and MDS. Does the neurologist typically hand off care to MDS at a certain point in the progression of Parkinson's disease? And can you comment on that?
Yeah, that's a great question. I think of it often as being related to ease of accessibility of both the movement disorder specialist and the neurologist. So there are parts of the country, and we're very fortunate here in Boston that we have a lot of movement disorder specialists in a very small area. But there are many places, even as close to us as New Hampshire and Maine, where there is not an easily accessible movement disorder neurologist. And so I do often get referrals from other neurologists who are treating a patient with Parkinson's disease and have hit either not sure where to go or want to know if there are new medications, and they'll send them down for, say, one yearly or a bi-yearly visit. And then they will see them in between to make sure that they're not having side effects of the medication. And so there is often communication between neurologists and movement disorder specialists. I would say that I try to see people upwards of 4 times a year. But if that travel gets very hard for people, I would rather they see a neurologist close to home in between than not come and see anybody. So that's how I often think of it. I do get referrals from neurologists quite often, and many of my patients will see both.
Thank you. One of the other questions we had was on medications, and that individual commented that sometimes the information that they maintain personally is different from the doctor and as it relates to medications and dosage. Is there any sort of recommendation that you might have for individual going to a doctor's office with updating the doctor on medications?
Oh, yes, I think I can handle this one. You know, we do give a list of suggested medications and what we think is the best evidence-based medicine or best evidence-based therapy that we can give someone. But really, at the end of the day, the most important thing is which ones are you actually putting in your mouth every day, or which ones are you injecting yourself with? Which ones are you placing a patch on your skin? You know, if we have a list of 12 medications, but you tell me I only take 3, then that's a conversation that you should have with your doctor. Because the next question should be, well, why not? Why aren't you taking medication A? Why aren't you taking medication C? And that information helps us to help you better. If you tell us, I don't take this medication because it makes me feel dizzy. I don't take this medication because it makes me urinate too much. These are things that we want to know and are helpful. Again, our goal is to help you. So we have an idea of where we want to head, but you are the most important person in this equation.
And many of you have probably the experience that once you were diagnosed with Parkinson's disease, all of a sudden your medication list doubled or tripled. It's unfortunate that we don't have many long-acting medications, and so you are often taking medications multiple times a day. And I only get a snapshot of what you're taking. You're taking these every day, and so what you're doing most consistently is the most important, not what I'm necessarily recommending, as Dr. Johnson said. So I need to know exactly what you're taking and how you're taking it. And if my records aren't up to date, bringing that to my attention is very important, because we need to do a better job on our end of making sure that we're updating the records so that our list is the same as your list when that gets passed on to another physician or seeing you in the next visit.
Thank you. One last question. We have an individual that has a very large healthcare team, so multiple individuals, up to 7. Is there anything that you would recommend for communication, you know, within that large healthcare team?
This is where I would highlight that I think the primary care doctor is essential. They are your hub. They are the person whose job it is to help coordinate all those people together and making sure that all those specialists are not prescribing meds that go against each other or aren't ignoring things that another doctor is trying to treat. I think that it's not necessarily up to you to get 7 copies of your neurologist note to then pass out to all your specialists. But if your primary care doctor gets everything, then they can help to coordinate all of that. Would you agree?
I would agree with that 100%. That is the role of primary care, is really oftentimes as the go-between to help understand your care and what is going on. You know, many times our specialists, as good as they are, can really be focused on the disease that they treat best. And that is perfectly fine. That's what we want them to do. But our goal is to say, well, you know, in addition to diagnosis A, they also have diagnoses B and C and D. And how can we manage that to kind of decrease what we call morbidity or bad things that can be happening in your life to allow you to have the best life that is possible?
So thank you, everybody. And I want to thank Dr. Johnson and Dr. Bissonnette for a fantastic presentation. Just a few additional things at the very end. One is to let you know this has been recorded, and we're going to be distributing this presentation to everybody that registered for the event. We're also going to be getting the information out via our newsletter. If you have any specific questions that you'd like us to answer, or any additional information that you have, is a need related to today's presentation, please reach out to the Information Referral Center here in Boston, 617-638-8466. We've got resources and referrals available. Additionally, we've got chapters all over the United States. If you have information, please reach out to your local chapter. Our organization provides education and support groups, symposiums, educational events. We have health and wellness programs throughout the entire US, not only live, but also virtual. We have fitness professional training and first responder training. We're on social media, on Twitter, Facebook, Instagram, and we also have a main repository with all of our information on the apda.org site. Each state has their own website. Again, I really want to thank the presenters today, Dr. Johnson and Dr. Bissonnette. Additionally, we've got a great presentation lined up next month, February 8th, 1 p.m., Yoga for Health. We've got a great person presenting, and we hope that you'll join us. We'll make sure that we reach out to you with that information. Again, I want to thank our two presenters, Dr. Johnson and Dr. Bissonnette, great presentation, and Kathy Thomas and Rosemary Owen for the help on the back end. Thank you so much and have a great day.